Good afternoon, everybody. I'm Dr. Phani Kumar from India, a land of excellent, amazing culture to a land of amazing opportunities. I'm glad to be here, present before so many distinguished specialists from various fraternities to present my stand on reconstruction of various maxillomandibular continuity defects. Okay. This is where I come from, and this is where I graduated from, Tamil Nadu, state of Tamil Nadu from India. And the above picture shows the college where I graduated from, Meenakshi Ammal Dental College, Chennai. And the below picture shows Sivar Institute of Dental Sciences where I work currently. And this is our team of surgeons and colleagues. And particularly I would like to point out to my guide and professor, Dr. R.S. Neelakantan, who has been extensively studying and researching in reconstructive surgery and more towards regenerative surgery. And today, I'd like to present a modality, a technique in reconstruction of various maxillomandibular continuity defects using transport distraction osteogenesis. Rather, it is a time for paradigm shift from reconstructive surgery to regenerative surgery. And Ilizarov, to recall, is the one who started lengthening of the bones using distraction osteogenesis, and the same he applied for, and he is the first one to apply for transporting using this modality of technique, transport distraction osteogenesis, for reconstruction of long bone defects as well. And this is Dr. Constantino in 1990 who applied the same principle of transport distraction osteogenesis for reconstruction of continuity defects in canine models, and then he applied the same over human subjects as well. And to look into what basically bone transport is, it is a technique wherein we create a bone and soft tissue to fill up a defect by moving a disc of bone and forming the new tissues behind it until the disc docks the receiving host bone. Looking into the biologic foundation, we have a residual host bone segment, and this is the transport segment, and this is the residual target bone segment. And in between, this is when you move the transport segment from which is created from the residual host bone segment through the defect, we have distraction osteogenesis taking place, and there is one more phenomenon happening ahead of transport segment, which is transformational osteogenesis. These are the two processes which continuously happen through the movement of the transport segment through the defect between residual host bone segment and the residual target bone segment. And if we have to look into types of bone transport, various bone transport, we have bifocal. Depending on the segments created, we can term them as bifocal transport distraction osteogenesis, trifocal distraction osteogenesis, and tetrafocal or pentafocal, depending on the number of bony transport discs we create for the reconstruction of various continuity defects in the maxillomandibular area. So not only by the number of segments, but also by the forces or stresses realized by the transport segment, we can state them as bifocal or trifocal or tetrafocal, and the force which is realized at the leading edge is the compression force, and the force which is realized at the trailing edge of the bone transport is the distraction force. Depending on the presence of, or the forces realized, the number of forces realized, we can term them as bifocal transport distraction osteogenesis or trifocal or tetrafocal or pentafocal. So what are the considerations we'll have to take into account when it comes to creating a transport segment? The prime importance has to be given to periosteal preservation, because this is the single most area which has to be on which the viability of transport segment depends upon. So we have to give a small incision as far as possible and minimal periosteal reflection during creating the segment, and then we will have to use abundant irrigation while cutting the transport segment from the residual host bone segment, and watertight closure of the transport bone segment once it is created. And when it comes to advantages of the bone transport or conventional techniques of reconstruction, usually what we do for reconstruction of continuity defects is we'll have to depend on free grafts or vascular pedicle grafts or microvascular grafts or any other modality, such modalities, wherein we need specialized skill and a steep learning curve too. And when it comes to bone transport, the advantages are there is no specialized hands or equipments required. There is no prolonged duration of surgery. It is very simple. And because there is no prolonged duration of surgery, it is cost effective. And here, as we transport the bone through the continuity defect, it again regenerates the entire lost tissue between the residual host bone segment and the residual target bone segment. So there is no bone grafting required, and so there is no donor site morbidity as well. Recreation of alveolar ridge with attached mucosa, buccal and lingual sulci, and distraction osteogenesis and osteogenesis is happening. So indications, where can we apply bone transport technique? Bone transport distraction osteogenesis can be applied to almost any case scenario, except for a few technical difficulties wherein we'll have to probably look into an alternative. If you look at this, this is a case where a transport distraction osteogenesis was carried out after following primary resective surgery, ablative surgery of a tumor, and this is a reconstruction. This is a case where a fibula graft was placed and which is failed, and as a secondary modality, as a salvaging surgery, you can perform bone transport technique in these cases as well. And in particular, when it comes to cancer ablative surgeries, the defects as a result of cancer ablative surgeries in irradiated bones, can we apply? Yes, we can. And limitation to bone transport is that if you do not have horizontal bone residual host bone segment, it is very difficult for us to create a bone transport segment, transport disc to transport the segment through the continuity defect. So an alternative which is contemplated has been you can do a bone graft. Once the bone graft is taken, probably that can be used as a bone transport to regenerate the entire thing. So when it comes to classification, how do we classify mandibular defects? We can classify basically into central and lateral continuity defects. Central continuity defects can be again symmetrical and asymmetrical, and lateral defects can be straight or arc depending on the extent of the defect. For example, if it is proximal to the second premolar, it is proximal to the second premolar. This is termed as a straight lateral defect, and if this is going to exceed the second premolar, it is going to go distal to the second premolar, anterior to the second premolar, then we have to consider it as an arc lateral defect. When it comes to vectors in mandibular reconstruction, what are the vectors we have to consider? We have basically 5 vectors. 2 vectors anteroposteriorly in the body region along the lower border of the mandible, and 2 vectors anteroposteriorly in the parasymphyseal region, and 1 horizontal vector in the mid-symphyseal region. So depending on the vector and also the defect, if the defect is distal to, as I told you earlier, if the defect is proximal to second premolar, it calls for a straight regeneration, and if it is any defect which is crossing the second premolar, calls for an arc regeneration. Reconstruction of central defects. When we have a symmetrical midline defect, probably trifocally we can distract with the 2 identical transport discs, which will give a better result. And in asymmetrical defects, it is always recommended either you follow trifocal or a tetrafocal or pentafocal distraction osteogenesis. Reconstruction of lateral defects when it comes to single vector defect. Single vector defect is where it is again proximal to second premolar and in the body region. You can go for a bifocal transport distraction, straight regeneration. And when it comes to any defect anterior to second premolar, that is distal to second premolar, if it is extending beyond that, you may have to choose for a bifocal or a trifocal arc regeneration again. So when it comes to types of devices which we used in our case series are the buried bar device for straight regeneration and buried ball device for semi-arc regeneration, curvilinear buried device, and an extraoral anchorage transport device for arc regeneration. These are the devices which could be used. And when it comes to clinical appearance of the regenerate, as I told you, we have full formation of the entire lost tissues in the defect. So instead of terming it as only a distraction osteogenesis, can be also called as distraction histiogenesis because it forms a complete ridge along with the basal bone, and also the lingual and buccal sulci you can appreciate, and the fully formed ridge helps in placement of osseointegrated implants, dental implants, for further rehabilitation of the teeth to attain a proper occlusion. And when it comes to radiological appearance of regenerate, initially it may appear, once the distraction is complete, initially it may appear as, with consolidated dense radiopaque bony densities, and also huge radiolucency which is between this area, host residual bone segment and the target bone segment. But as and when the time progresses, you can appreciate it converts into a complete ossified region. So if you take a CT of the regenerate, you can very well appreciate the hyperdensity of the, as if you have a natural bone all over. It is identical to, in every manner, to the original bone which is present in the host. When it comes to ultrasound appearance of the regenerate, it appears as mixed echoic area, and also it can be appreciated when we take an ultrasound. It is also helpful for us to study the viability of the transport segment as well as the viability of the distracted callus. So when it comes to, I'd like to show some case reports where we have applied buried bar straight regeneration device and also arc regeneration. This is one such case where we had to resect the mandible, segment of the mandible, wherein the length of the defect was 65 mm and the length of regenerate achieved was 45 mm. And immediate post-op, after creating a transport segment with the buried straight device in place with the transport segment transfixed, after completion of the distraction, you can appreciate there is formation of the bone, and also these teeth, you can appreciate the teeth have moved along with the transport disc to the final position. And this is the reconstruction plate which is left in place in order to give the functional advantage. And this is the intraoral picture of the same patient with a well-formed bridge with deep buccal and lingual sulci, and implants, also osseointegrated dental implants were placed, and a complete rehabilitation was given. And as you can appreciate, the placement of the implants within the distracted segment, distracted bone, and this is newly formed bone which was helpful for placement of osseointegrated implants, and implant supported denture was given for the same patient, and a reasonably good occlusion was achieved. And this is another case wherein we had to resect the an entire segment of the mandible with leaving a defect of 65 mm, and the entire length of 65 mm regeneration was achieved in this particular case. And if you can see the preoperative and immediate post-op. As in the earlier case, you can see the transport segment is in place, which is created and with the buried transport device. And then this is the final position during the consolidation period. And as I said, immediately when you take radiograph, you may not appreciate the ossification completely, but as and when the time progresses, you can very well appreciate the consolidation of the distracted bone. If you take a CT, you can very well appreciate the ossification between the transport segment, trailing edge of the transport segment, and the leading surface of the residual host bone segment. And in this particular case, this is the result we could achieve post-consolidation before the bridge, and after the two supported FPD, this is the result. And can we apply the same principle in maxillary continued defects as well? Yes, very well, we can apply. And ever since the transport distraction osteogenesis was proposed by various authors like Elizarov, Constantino, and many others, when it can be applied to mandibular distraction osteogenesis, and a good result could be achieved. Yes, in mandible with its vast vascularity and cancellous bone, definitely it can be achieved with a better result. When it was first applied by L.K. Chung in animal models, and the maxillary distraction was achieved, transport distraction was successfully done. And even in our center, we performed quite a few maxillary transport distraction, and this is our first case which we published. And this is one of our first cases wherein we had to operate for posterior maxilla. Subtotal maxillectomy had to be done, and has to be performed for a maxillary keratocyst. And post resection, you can appreciate the defect, and the transport segment was created from the healthy residual bone segment, and the same was transported. And upon completion of the distraction through the defect, the histiogenesis you can appreciate with good formed ridge, and also the entire tissues in place. And then even this case was given rehabilitated with a fixed partial denture. And the problem or the limitation with the straight device when it is used in maxillary area, because of the configuration of the maxillary arch, it is pretty difficult to achieve the arched form as in original form of the maxilla. Here we have a buccally oriented straight regeneration happening, not conforming to the arc shape. So in another case where we had a gunshot injury residual deformity, residual defect, here we had to regenerate from either sides, taking trifocal distraction osteogenesis using a buried curvilinear device. And the result we could achieve is this. In the transport segment, on docking and consolidation, this is what we observed. And this particular patient was given osseointegrated implants, and implant supported denture was given during rehabilitation. And coming to the highlights of transport distraction osteogenesis, can it be performed in irradiated mandible? Can it be performed in children? Can it be a salvaging procedure? Can it offer adequate function and aesthetics? Can it suit our patient's pocket? Can we, the maxillofacial surgeons, too? Yes, as I told you, to again recall upon, there are quite few studies wherein it was performed in irradiated mandibles. And this is our case wherein we performed in irradiated maxilla, where this is the kind of result we achieved in our center. And then can it be performed in children? Yes. Shen was the first person to perform in a patient as young as a 24-month-old child, and the results were achieved. And this is one particular case wherein transport distraction was applied. Can it be a salvaging procedure? Yes. This is a case where a resection of the mandible was done and it was reconstructed further with a fibula graft and it failed. And upon further contemplation for reconstruction, we opted to go ahead with transfer distraction osteogenesis again, and this is the result we achieved. And post-consolidation CT also gives the amount of regenerate that was achieved, and also in this particular case also we could give osseointegrated implants and implant-supported denture. Can it offer adequate function in aesthetics? When it comes to conventional reconstruction using microvascular fibula grafts, the problem with the rehabilitation is the height of the ridge is not achieved in case of conventional reconstructions. But in case of transport distraction histogenesis, very well, yes, we can achieve the height of the ridge, wherein it allows us to again rehabilitate the patient with the original vertical dimension when occlusion is established. And this is the result we could achieve using transport distraction histogenesis or distraction osteogenesis with complete formation of the ridge, which is not possible with the conventional approaches. And microvascular surgery, definitely it requires a very steep learning curve, and also it is very pretty difficult to achieve the kind of results what we achieved in case of using transport distraction osteogenesis as a modality of reconstruction for continuity defects. And this is one another paper which we published from our center, transport distraction osteogenesis for maxillomandibular reconstruction, current concepts and applications, wherein we have tried to project whatever results we achieved and whatever suggestions we had for future research. Thank you.
Any question?
Very impressive results. Do you ever make the turn and go up over the angle?
No, we did not try that. Basically, what we look into when we, primarily as dentists, what we look into functional aspect is that function of the joint can be achieved using a reconstruction plate very well. If you can preserve the condyle during the resection, the reconstruction plate which we place even after distraction, we have to have that reconstruction plate in place to give that joint function, and that is taken care of. And when it comes to horizontal defects, wherein we lose dentition, that is where the establishment of recreation of the entire functional component comes in. So our focus was totally into regeneration of the horizontal ramus rather than a vertical ramus.